Well, we have Mrs. Berry, which is a 35-year-old lady, significant history of alcohol abuse, and she has no other comorbidities. She presented with weight loss and abdominal pain, and we did for her MRI of the liver. We subsequently showed a single lesion about 7 centimeters in the right loop. There were no cirrhosis. And we discussed the case last week, and we agreed from the last MDT that we are going to go for a biopsy. Do we have the pathology?
We do have the result. So the liver biopsy confirmed the presence of a low-grade dysplastic area with mild increase in cell density with a clear trabecular arrangement than the adjacent normal parenchyma. And these features are in keeping with hepatocellular carcinoma.
Thank you, Dr. Kumar. The patient is actually fit and well. The blood tests are all within normal. His performance is 0, and he has no evidence of portal hypertension. For the panel, what do you think we should go from here?
Stage 0 to A, according to BCLC, includes either single tumor of any size or up to 3 nodules 3 centimeters in size. In addition, patients should have preserved liver function, Chau I and ECOG 0. These patients are better served with surgical resection. In this patient, as the tumor is in a good location, she would likely have adequate liver reserve post-surgery. If surgery is not possible, SBRT would be a good alternative. This patient is outside Milan criteria as the tumor size is more than 5 centimeters and hence not a transplantation candidate.
Thanks for coming to the clinical skills exam. We are going to ask you questions from your practice. So take your time, think of the questions, and then give the answer. All right?
All right.
Good. So you have a 45-year-old gentleman who is fit and well, but came in with painless jaundice. An ultrasound showed a pancreatic head mass that's causing biliary obstruction. What would you do next?
Well, I would do a CT scan to better look at the tumor and the nearby structures.
Well, a CT scan was done and it confirmed a pancreatic head mass that is completely encasing the celiac axis, but it does not involve the SMV, SMA, or hepatic artery or vein. There are no pathological appearing lymph nodes. The repeated bloods showed a further rise in the bilirubin, which is now 200. What would you do now?
I will ask the gastro to do an ERCP for stenting and to acquire tissue for sampling, and I will do a PET CT scan to complete the staging.
So this is what happened, and the bilirubin started to decline. The PET ruled out any distal metastases, and the biopsy confirmed an adenocarcinoma. Now, can you tell me what is the patient's current T stage and how would you proceed?
A T4 lesion indicates an involvement of the celiac axis, superior mesenteric artery, and or common hepatic artery, regardless of the size of the pancreatic cancer lesion. This patient has stage 3 local advanced disease. In the NCCN guidelines, if the patient undergoes systemic chemotherapy or chemoradiation and has a good response, surgery can be considered. Local advanced tumors where surgery may not be possible in the NCCN guidelines include the following: pancreatic cancer at the head or uncinate process with more than 180-degree contact with the SMA, pancreatic cancer at the head or uncinate process with more than 180-degree contact with the celiac axis, pancreatic cancers at the body and tail with more than 180-degree contact with the SMA or celiac axis, pancreatic cancer at the body and tail with contact with the celiac axis and aortic involvement, pancreatic cancer at the head or uncinate process or body and tail with an unconstructible SMV or PV due to tumor involvement.
Dr. Ahmed, can I consult you about a patient of mine, please?
Yeah, sure, please, go ahead.
I actually have a 75-year-old male patient, and he's diagnosed with hepatitis B liver cirrhosis. He was just recently admitted with us with right upper quadrant pain. We did for him MRI, and we found an HCC in the left lobe about 3 centimeters in size. He was discussed in the MDT, and they found him not a surgical candidate because of poor performance.
Right, okay, so what is this Chau I score?
Well, actually, his liver function tests are very well. His child score is A, but I forgot to mention that he has a portal vein thrombosis.
Gosh, now another good therapeutic option is out of the list.
Arterially directed therapy can be offered to selected patients with unresectable HCC, providing the arterial blood supply to the tumor can be isolated without excessive non-target treatment. This therapy is made possible by the dual blood supply to the liver. While the majority of blood supply to the normal tissue comes from the portal system, blood supply to the tumor comes from the arterial supply. The different arterial directed therapies include radioembolization, chemoembolization, and blunt hepatic artery embolization. According to the NCCN guidelines, chemoembolization is relatively contraindicated in the following conditions: child PUC, portal vein thrombosis, bilirubin more than 50 micromole per liter.
Mr. Ali, thank you for coming today to the clinic. I know that you have met the surgeon last week, and I'm sure he has filled you in. But do you mind telling me what you have discussed in the surgical clinic?
Basically, about a couple of weeks ago, I woke up with yellow eyes, just suddenly, and that freaked me out. So I went to seek help, and eventually they did a CT scan on me, which I was told that showed a lesion in the biliary trees inside my liver. And I was also told that there were some other tiny lesions in the liver as well, scattered all over. A biopsy was taken, and that's when I saw the surgeon last week, and he sent me to you.
Well, I'm sure this must have been heavy news for you. I also understand that they put a stent for you in your biliary tract, and this must have relieved your jaundice.
Yes, indeed, doctor. Everything has gone back to normal. I feel really normal now.
This is very good that you're feeling well, and your performance is very well. You are 50-year-old, and we have discussed in the committee options for therapy. We have also asked for further testing in your pathology sample, and I'm sure these tests are going to be helpful in the treatment.
Biliary cancers are highly aggressive and often present as stage 4. Based on the results of the ABC02, the phase 3 study of gemcitabine cisplatin versus gemcitabine alone, the dual therapy has a category 1 evidence to be given to patients with metastatic bile duct or gallbladder cancers. The median overall survival was 11.7 months in the combination arm and 8.1 months in the gemcitabine single arm. IDH1 mutations occur in about 13% of patients with intrahepatic cholangiocarcinoma. In a phase 3 placebo-controlled study of ivosidenib, which is a small molecule targeted therapy for mutated IDH1 in the second-line setting, progression-free survival was significantly improved with the treatment compared to placebo, and the ivosidenib was well tolerated. FGFR2 gene alteration are involved in the pathogenesis of cholangiocarcinoma. Pemigatinib is a selective potent oral inhibitor of FGFR1, 2, and 3, and this drug has shown efficacy in those patients. Currently, the FDA approved pemigatinib for the treatment of adults previously treated unresectable local advanced or metastatic cholangiocarcinoma with FGFR2 fusion or other rearrangement. Pembrolizumab could be an option if the patient has deficient mismatch repair.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share and subscribe, And don't forget to join us every Thursday, 5 p.m. Greenwich time.